So moving to the next session, this is Ballroom B, and we're going to keep severe osteoporosis right here. So we're going to start this symposium on severe osteoporosis with a case presentation. Actually, just the beginning of a nightmare, so I hope you enjoy. So those are my disclosure. And the case presentation is a case, the treatment started in 2011. It's a female, 71 years old, with severe back pain and the degenerative scoliosis, some irradiation for the left leg pain with no neurological deficit. And she's a very sick patient. She's a diabetes, obese, hypertension, and she presents with this situation. So the CT scan shows mild scoliosis, L2 to L5 apex, no sagittal or coronal imbalance at that time, and she was complaining for severe back pain. So MRI shows hemorrhagic changes, mild compression on the left side, L4-5 foramen, and some allostasis, and not really important central canal stenosis. So here you can see the axle. The BMD of this patient shows very good bone quality at the spine itself, and osteoporotic patient on the hips. So because of the risk of this patient, obesity, diabetes, and hypertension, we decided to do as minimal as possible at that time. So we performed for her a 3-level lateral standalone fusion, and she did quite well in the post-operative days, and she come back to the office 3 weeks later complaining of severe back pain at this time. So we tried to handle this clinically, and with 6 weeks, she started to develop a left side irradiation, so a left leg pain with subsidence, a clinical subsidence in L4-5 level, and also in 2-3 level. So here's the MRI. And I'm going to stop right here and ask for James Mock to come here to the panel, and we're going to present on pre-operative strategies to enhance bone quality in patients scheduled for lateral fusion, evidence, and expert opinion. So we can talk about this case after the presentations. Thank you.
Hi, I want to thank the SOLAS for inviting me to be on this panel. Actually, I feel like I should be in the other room learning about business, but I'm glad to be talking to you all about preoperative strategies to enhance bone quality in patients scheduled for fusion via a lateral approach. I have no disclosures. So everyone in this room has the same goal, and that's to relieve pain and improve the function of our patients. And for those with clinical spinal instability, many times that involves a successful fusion. And as surgeons, it's probably fitting that in these meetings and most of what we do, we focus on surgical technique. But today I'm going to make the case that medical optimization has an important, if not critical, role in achieving a successful fusion. So I'm going to be talking about osteoporosis, including the preoperative evaluation as well as medical optimization. The World Health Organization definition consists of 2 components: decreased bone density and loss of bone microarchitecture quality, which leads to an increased risk of fracture. The pathophysiology is because of an uncoupling between osteoclasts and osteoblasts. Osteoclasts resorb bone, so they make it weaker, and osteoblasts build bone, so they make it stronger. And this is the way I think of osteoclasts and osteoblasts. Now, when we're young adults, the osteoclasts and osteoblasts work in tandem. But as we become older and lose estrogen, especially in postmenopausal females, there's an increase in both osteoclast and osteoblastic activity. The problem is that the osteoclasts far outstrip the osteoblasts, and that leads to a net resorption. The problem is made worse because the osteoclastic activity releases calcium, and so the body absorbs less calcium because it doesn't want to cause hypercalcemia, leading to further demineralization of the bones. So lumbar spine fusion requires a high level of bone resorption, bone formation, and bone remodeling. So the metabolic derangement that I just showed will cause a significant challenge for those of us trying to achieve lumbar fusion. And some would say it's obvious that this would lead to osteoporosis-related complications. This is a series out of Mayo. 2 surgeons, a pretty typical degenerative practice, posterior thoracolumbar fusions. 10% of the patients had osteoporosis. And not surprisingly, the patients with osteoporosis had very high complication rates, 50% of any complication and 46% of pseudoarthrosis, and both of these were statistically significant. But we're SOLAS. We don't perform posterior interbody fusions. We do lateral interbody fusions. And we have this thing called the apophyseal ring, and it's really strong. And maybe that mitigates the risk of osteoporosis. And there might be something to that. This is a cadaveric study that correlated end plate strength with bone density. They looked at 155 lumbar vertebrae, most of which had t-scores less than -2.5. And what they did was they divided the end plate into a lot of these little sections, and then they divided into 3 groups. They either removed the central portion, leaving the apophyseal ring intact, or took off the entire end plate, and then they tested it to failure. And this was their result. The y-axis is a load to failure, and the x-axis is bone density. And what they found was that when you remove the central part only, meaning you leave the apophyseal ring intact, there is no difference from an intact end plate, and both those groups were better than the group that had the entire end plate removed. But they also showed that, not surprisingly, the lower the bone density, the lower the load to failure. So what this suggests is that lateral interbody fusion is a good approach to osteoporosis, but low bone density is still going to be a problem. And that's associated with subsidence, which remains an important problem with lateral interbody fusion. So the group out of University of Pittsburgh has published their large series of 335 standalone lateral interbody fusions. They had a subsidence rate of 9%, and about half of these patients required revision. All of these had high-grade subsidence defined, I believe it's greater than 50% of collapse around the interbody implant, not 25%. And then they looked at the 80 patients for whom they actually had DEXA scans. And what they found was that of the patients with subsidence, almost 80% had a t-score of less than -1.0. And on the flip side, of the patients without subsidence, 63% had a t-score greater than -1.0. So they calculated some sensitivities and specificities based off of that. And this was, of course, highly statistically significant. So I think that we can say that osteoporosis is highly clinically relevant to lateral interbody fusion. And it's highly relevant because it's also prevalent. So if you use the WHO definition of a bone mineral density more than 2 standard deviations worse than a young adult female, the prevalence in America is 60% of adults greater than 65 years old, and that becomes 25% of women. Vitamin D deficiency is also not uncommon, and I want to kind of put the framework on smoking. That's something that, as surgeons, we think about all the time, and perhaps we should think about osteoporosis more as well. So the preoperative evaluation should include a recent DEXA scan, a vitamin D level, checking the parathyroid to rule out hyperparathyroidism and other causes of secondary osteoporosis. Now, the DEXA scan, as we heard earlier, is the mainstay of diagnosis, and what that is, it's these 2 low-energy beams that are shot anterior to posterior. The radiation is converted to a bone density, and that's converted to a T-score or a Z-score. The problem with it is an anterior to posterior shot, so it includes all the posterior elements. Spondylosis will also distort the score. And finally, you can't focus on a specific area of interest. And all of these things lead to some problems for using a DEXA scan in your surgical decision-making. So there's this interesting alternative technique of using bone density assessed by CT scan Hounsfield units. These are also a measure of tissue density using radiation, and it's standardized to 0 for water, -1,000 for air. And there's great attraction to this technique because you can look at only the area of interest, and many of our patients already have CT scans, and it's easy to measure Hounsfield units with some basic PACS software. So it's been shown that low Hounsfield units are significantly associated with pseudoarthrosis. Schreiber has published a lot about this. They looked at 28 patients who had standalone lateral interbody fusions and a postoperative CT scan. More than a quarter of the patients had pseudoarthrosis, even though almost all of them received BMP. And the patients who had a solid fusion, both at the fusion level and the distant level, had significantly higher Hounsfield units than the patients who had pseudoarthrosis. And interestingly, they also saw that the patients had higher Hounsfield units at the fusion level than distant levels. And they hypothesized that that's actually a reaction to the BMP. But there's some barriers to this. The first is that there's not really a large body of literature, so there's no applicable threshold units that surgeons can use. And also, when you correlate it with the groups that we use T-scores for, although there are significant differences between them, there's also these thresholds. There's a lot of overlap, so it's really hard to apply a specific number to a specific decision. So let's go back to our pathophysiology slide here. And so with medical optimization, we're trying to balance the osteoclastic activity and osteoblastic activity. And the first thing to do is just make sure the patient has adequate vitamin D. Because if there's not enough calcium in the blood, the body is going to break down even more bone, which is going to exacerbate the osteoporosis in order to replete the calcium. The medical treatments are aimed at slowing down the osteoclast, that's what Evista and Prolia do, or stimulating the osteoblasts, and there's only one medication in the United States that does that, Teriparatide. I'm going to start with vitamin D because it's cheap, it's easy to diagnose, and it's straightforward to treat. Vitamin D is absolutely critical for the intestinal absorption of calcium. It accounts for over 85% of this. There's no consensus on a level, but most people agree of 30 nanograms per milliliter. At least 2 studies have shown a very high prevalence compared to the normal population, and it's treated with either daily or weekly vitamin D. I should mention that if a patient is obese or has a malabsorption syndrome, the amount of vitamin D that's needed can be very large. The clinical evidence for bisphosphonates is quite strong. Earlier on, because bisphosphonates interfere with bone remodeling, it was thought that they would interfere with bone fusion as well, and the animal studies had some kind of conflicting evidence. But these are 2 randomized controlled trials with remarkably similar designs, although one's out of Japan, one's out of China. These are patients who underwent posterior lumbar interbody fusion without cages and with local autograft. They were randomized in Japan to either lendronate or vitamin D. In China, they were randomized to either lendronate or placebo. What they found was that the Nagahama study showed that solid fusion was achieved in 95% of the lendronate group and only 65% of the vitamin D group, and that there were actually a difference in clinical outcomes as well. The Chen study showed no difference in fusion rates at 12 months, although every other time point did show a difference. They also found a statistically significant improvement or difference in oswestries, and they also found these other benefits, lower vertebral compression fractures and higher BMD in the femoral neck at 1 year. Teriparatide also has good clinical evidence. These are 2 other prospective studies, both out of Japan. Ebata randomized patients to either teriparatide once a week or placebo for 6 months that started at the time of surgery. They all received calcium. Complete fusion was seen in 69% of the teriparatide group and only 35% of the placebo group. Although there is no difference in ODI scores or T-scores, keep in mind this is with 6-month follow-up. Otori took the first half of patients, gave them risendronate. The second half of patients got teriparatide. Fusion rates were also higher in the teriparatide group, and they also did not find any significant difference in clinical outcomes. Again, this is 12-month follow-up. So the recommendations from these papers are not to discontinue bisphosphonates because they might actually be beneficial not only for the fusion, but for the other benefits of osteoporosis therapy, and consider teriparatide. And this is kind of an interesting study. This is by Inui, also out of Japan. They randomized patients to either teriparatide for at least 1 month pre-op or no treatment, and they looked at the insertional torque of the pedicle screws that were placed at the time of surgery. And they found that the patients who received teriparatide had significantly higher torque than the patients who did not, which seems to suggest that the qualitative improvements in the bone occur very early on and can actually be felt by the surgeon. So why don't we give teriparatide to everybody? Well, there are some important barriers to this. The first is that it requires evaluations that a lot of surgical clinics aren't really equipped to do. It's expensive, so insurance companies usually require pre-approval, which creates an administrative burden. A lot of patients don't like the thought of injecting themselves every day. And there's also this concern about cancer risk because of some rat studies that showed osteosarcoma. There's been no reported case of osteosarcoma despite 1 million patients who have received Forteo, although it remains contraindicated. But perhaps the biggest barrier is out-of-pocket expense. And I know SOLAS is a very international meeting. I think it's one of its strengths. I want to give the audience a little insight into the challenges of American healthcare. So most patients who have Medicare get their drugs through what's called Medicare Part D, which provides prescription drug coverage. And here's an example of a plan from Illinois. It looks pretty reasonable, $24 per month, $405 annual deductible. Although for a drug like Forteo, the patient has to pay 25% in coinsurance because it's what's called a specialty drug. So you go to the Medicare website, you plug in what medications I'm on, you could calculate out-of-pocket expense. And so in the first month, I pay my deductible, and then I pay 25% of the coinsurance. That's in June. And then I go in for the pharmacy in my second month, and I hit this thing called a donut hole. What the donut hole means is that when the plan has paid $3,750 for your drugs, it kind of cuts you off, and then you have to reach this out-of-pocket maximum of $5,000, and then you reach this thing called catastrophic coverage where you only pay 5%. So in other words, you have to pay $4,600 per year. I practiced in the south side of Chicago. The donut hole is more like a black hole because none of my patients could ever meet $5,000 out-of-pocket expense, especially if you consider that the average Social Security check is $1,400 per month. But there might be hope. The Forteo patent expires in August. I'll be interested to see if there's a generic that comes out. And a competitor has also just been approved by the FDA, and it costs about half as much. So I'm going to conclude by saying that all of us want to achieve a successful fusion, and through meetings like SOLAS, there have been great advancements made in technique, implant design, and biologics. And I would argue that medical optimization remains an area of great potential. And as surgeons, we're the ones who are ultimately held accountable for the success or failure of our fusions, and it's hard for me to imagine an endocrinologist or another medical doctor who would consider themselves a stakeholder in this. Thank you very much.
Thank you, James. Microphone. Thank you, James. I'm going to move to the next presenter. Next presenter is Dr. Luis Pimenta.
Yeah. We heard that lateral is good for osteoporosis, and my point here will be talking about a little bit of the cage size and the risk of bone failure. I still have disclosures. What about bone failure in lateral? There are bone factor, mechanical factor, and surgical factor that we have to consider. But important in our earlier studies, we found that the cage coverage on the end plate is critical to support the mechanical role of the interbody cage. So you can see in this graphic that the lateral approach is the one that has the best chance to cover more and support on the best bone. Everybody knows this here. And the biomechanical studies that we performed years ago also show the same thing, showed, for instance, that a large standalone LLIF would have the same stability as a TLIF with bilateral pedicle screws. And we also studied the difference between 18, 22, and 26 millimeter. We actually had some experience with 30 millimeter wide because we know that growing and being bigger, the support, in general, the success comes together. So it happens that size matters in this case. Why we don't use 30 anymore? Because at some point, if you try to implant so bigger implants, you risk to open the ALL and then your results decrease. That's the reason we stop planning to go into 30. We also studied the difference in the bench test, and we found similar results showing that 26 is stiffer than 18, even with pedicle screws, and also similar and better to TLIF with bilateral pedicle screws in a standalone fashion. What about subsidence and the radiological impact in clinical studies? We know that subsidence, when happens, may lose indirect decompression, lose lordosis, cause pain, and pseudoarthrosis, and sometimes even a vertebral fracture. So the sizing of the cage in height is really important, and here we will study both hyper and undersizing. So when we deal with a collapsed disc, there is a tendency for younger surgeons that they want to restore the lordosis, meaning that they look to the normal disc height, and they want to make the collapsed disc as high as the normal disc, and this is a mistake. So we don't want to over-distract, because results in general more subsidence. We learned this with experience, so we always recommend using only, in very collapsed cases, only 8 or maximum 10 millimeter high cages. So this is what happens, and may happen even fractures. Of course, the screw in this case has an important factor, like the place of where the screw is induce the fracture. Anyway, insufficient height, what happens may cause migration, and can also allow what we call seesaw effect, an instability effect, and with the motion come back the subsidence and bone fracture. These are the studies that we published in the past, showing that the 22 were only 10% of subsidence in a standalone fashion versus 30% of subsidence when we used in the past 18 millimeter wide cages in a standalone fashion. How big AP should we go? And that's what we did, and I mentioned before. We try to go bigger, bigger, bigger. Of course, there is a limit by the size of the patient, the level that you implant, the tendency. I always have questions like, should we implant more anterior, more posterior? If I want indirect compression, should I implant more posterior for indirect compression? The easiest answer should be right in the middle, not too much anterior, not too much posterior, but requires a good technique, requires a big opening of the retractor, and ability to go very posterior with your first guide wire to allow a big opening to place those big cages. So we know now that cage sizing in lateral has to support the epiphyseal ring. So also the length of the cage is important, and I heard that the LLIF reduced the length. This is a concern, in my opinion, especially when we deal with osteoporosis, because you don't cover the cortical bone. If I have to choose between one that's shorter, too short, and too long, too large, I would prefer the too large, even hanging outside the apophyseal ring, because I want to cover, especially when it has those osteophytes. I always say that osteophytes are our friends because they are very good bone, sometimes the only good bone for the older patient. So it's really important to choose the adequate cage, but also choosing supplementation depending on what kind of pathology we are looking. Instability, listhesis, osteoporosis, previous surgery, iatrogenic instability, all are interesting reasons to supplement. So we always we pay attention to subsidence in regard to radiological findings and complications. Not all subsidence are equal complications. Some subsidence, minor subsidence, they fuse well, they don't reduce your lordosis, but the one that are over 25 and 50% of the disc height loss, these are the ones that cause problems and frequently reoperations. How much stiffness is needed to achieve fusion is also an unanswered question. How much soft is allowed to prevent failure? We don't know, but bigger is better and size matters. Thank you very much.
Thank you, Dr. Pimenta. I'm going to move to Pedro Berjano. I'm going to present on catastrophic vertebral body fractures after interbody fusion and how to identify and manage it. Thank you, Pedro.
Are you ready for complications? Because now it looks that I'm the expert in complications that I am. This is the time I am the real expert. So these are my disclosures. And look at this. This is a 70-year-old lady, non-smoker, BMI 27, T-score minus 2.2. So it's not severe osteoporosis. She's a wealthy lady, and at the beginning of my travel in indirect decompression, I proposed to this lady doing something that was not standard care. So I proposed doing indirect decompression, unilateral pedicle screw, and of course, it was quite successful. 5 days post-op, the patient was happy, complete relief of the claudication, of the leg pain. She was walking, and she went to physical therapy. It was July. Then I went on holidays, and 1 month later, she came telling that the physical therapist was asking her to bend forward, and she felt pain. Here you can see that there is some difference in the upper end plate of L5. 1 week later, you see some more subsidence. And now she is desperate, but I'm on holidays, and she doesn't find me. So she goes to a different surgeon in Switzerland, not in Italy, and he says, who is the idiot that did this surgery for stenosis? He did the wrong procedure, so now you are going to go to the best Italian surgeon, who is a friend of mine, and he called this surgeon, who, by chance, I was training in lateral surgery. And he said, okay, this is not an idiot, he knows what he does, and he saved my life, probably, and a lot of money. And here you see the CT scan of this lady. And I think that the most important difference you can see on your right in the screen is the bilateral failure of the lateral walls. And that's the difference between subsidence and fracture. I think that's the key, because here you can see that you lose the structural continuity of the spine, of the anterior column, and that makes the difference in terms of pain. So the patient was in excruciating pain. Claudication relapsed in a much more severe fashion. She had one side sciatica continuously. So I was invited to revise this case with my friend, and what we did was posterior decompression and exchange of the instrumentation compression of the construct, and she healed uneventfully. So that time it was good. That time it was good. So next case, some years later, now indirect decompression is standard of care. And here, this is a lady with a past excessive consumption of wine. She was a smoker, but she is no longer. I didn't do any osteoporosis testing, but I felt she didn't have a good bone quality. So I remember this is one of the maybe 3 cases in my life where I planned augmentation during the lateral approach. And here you can see it's a typical case for indirect decompression, and I did good reduction. That cement is not through the pedicles. It's directly laterally into the vertebral end plates in order to increase the resistance of that bone. So 3 days after she went home, 1 week later, she fell at home, excruciating pain, and then she was not the best patient. She had a sort of pneumonia after surgery, so I didn't want to bring her back to the OR. So let's wait and see. So a brace and wait, and this is one month later. This is 2 months later, and she has more and more pain. And here you can see the comparison. You can see how this tilt into the L5 screw that now is next to the lower cortical. So in spite of that cement, in spite of the fact that the cement was closer to the end plate in L5, it failed there. So I learned that at least that amount of cement is not going to work, even with bilateral pedicle screws. So what to do now? Well, the patient was not the best one, and here I listened not to my brain but to my emotions, and I did something minimal, and I did augmentation. So I went through the S1 pedicles into the L5 vertebral body, and I did vertebroplasty of L5 and discoplasty because I was concerned about the resistance of the lower level, and sacroplasty. So, do you think it worked? Worked? Not worked? Didn't work? It didn't. It didn't. And so finally I had to revise her to this construct. And it has been about 4 months of trying to, and at the end, this was the only thing that solved the problem. An extensive construct, much more solid, with rebalancing of the patient. This 1 year later, the history doesn't seem to finish because now you see some spondylolisthesis in 3/4. So I'm scared, but now she's doing well. You can see a posterolateral fusion mass and all that. So, next patient. This is a 49-year-old male, 76 kilograms. No doubt he doesn't have any osteoporosis. And one of my young colleagues does his first patient LLIF without a senior surgeon next to him. So he's so keen to increase the lordosis in this case of L5S1 discopathy that he has some, you can see some irregularity in the sacral end plate. And this is 3 months later. The patient has increasing pain. He's disabled. So you can see here there's a fracture and some bone resorption around L5S1, and that's a disaster. And so we rescue him. And this is my responsibility that I said, okay, you are expert in doing deformity, so you are going to take this case. And do you think that this worked? No? Yes? Okay. It didn't work. This 9 months after, and the patient has very severe pain. And you know, the patient had healing in L5S1, and we saw some osteolysis around the screws in L4. So it's only the lack of a cage. We interpreted this as a problem of sagittal alignment. So the construct was robust enough at the beginning, but the alignment was not good. So the torque on the construct was too high. So the rationale for the revision was to increase the lordosis and not to extend or only by one level the fusion. And this is what we did. LLIF with very tall cages and Ponti osteotomies to shorten the posterior column. And after this, the patient did well. So these are cases apparently subsidence, but it's much a bigger problem, as you can see. Okay, even worse disaster. This is an unsolved case, yes. She's 65-year-old, but very badly kept patient. You can see this lordosis extending up to T8, which is a huge compensation. And in this case, she was in a poor condition. So the program that my colleague decided to do was LLIF to increase the lordosis at the lower lumbar spine, and then doing some XLIFs in posterior percutaneous. And the plan was good, and he staged first the LLIF and then the posterior. Okay. Very good LLIF, 20 degrees, good correction down there. You can see some kyphosis now in L4-5, but it doesn't matter so much because we are going to fix that in a couple of weeks or 3 weeks back. We didn't have time. 4 days later, you can see this fracture of S1. It is really catastrophic, and probably the screws very close to the midline, the plate built on the cage, play the role to create a stress riser at that plate. And here you have again a loss of the continuity of the anterior column. And this was the revision, and very unhappy one because my colleagues had difficulties in doing proper TLIFs, and you can see there's some subsidence. Probably the length of the construct is not enough, and at the end, this immediate post-op. Immediate. Okay, I'm sorry. It is 1 month later with a junctional fracture. And now the patient doesn't want to be touched again, and it's an unsolved patient. And probably the time to, she needs some time to understand she cannot bear this situation, and she will undergo complex surgery. So it's a huge problem having this kind of failure. And probably this is the last case. This is a lady with a apparently innocent L4 fracture, but if you look at the MRI and you look at the CT scan, there is a discontinuity of the anterior column. So a colleague did this construct. The idea was good. The execution was not so good, and the patient was doing very badly, very badly. So this is not a catastrophic fracture. It is a catastrophic mistake on this patient. And here you can see the results. So this patient needed an extension to the ilium and this kind of construct. And she did well. She did well. And 9 months post-op, the result is stable. And the patient now is doing properly. So you can see that subsidence is a small problem, as Luis has been stating, but catastrophic fracture, when you have that loss of continuity of the anterior column, can be a very severe problem. And this has received some attention in the literature as soon as 2010, I believe. And here's one paper reporting on 2 cases that were treated conservatively. Another 2 cases treated, one with vertebroplasty at the very initial stage of the split fracture, and you can see that riser of the lateral screw as the probably likely initiator of the fracture. This one, another report by Adam Cantor of 2 cases with very similar fractures. It's a tilting cage that causes a coronal fracture of the vertebral body, and they needed both revision with posterior hardware. But look at this. It has also been reported by Vincent Arlet in TLIF cages. This report of 2 cases with TLIF and the catastrophic fracture. So probably it's less likely in TLIF, as we saw, because the center of the end plate is less relevant biomechanically. You can have subsidence there, but you will not lose the integrity of the anterior column. But if you have an aggressive cage, maybe the result can be similar to lateral cages or to anterior. And this case is very similar to the last one I showed you. It's a case with an anterior LLIF cage and screws that causes a risser and coronal fracture in the lower vertebral body, like the S1 case I experienced. So I think that conceptually there are three types of failure. The first one, and I'm not talking about subsidence, but of failure. The central one is more common in TLIF and less in XLIF or ALIF. It can increase pain or be asymptomatic. It can cause loss of alignment, but it very seldom needs revision because the patients do poor but not so bad. The second one is when you have both lateral wall with or without coronal split, and it's more likely to happen in lateral approach, and then in TLIF and then in ALIF, and you can have also a collapse of the anterior wall. It's optional, but in these cases symptoms are very severe, and you lose the alignment, or sometimes you can keep neutral. And finally, you have an anterior wall failure with coronal split, and it's more typical in ALIF. And you can consider that plates and screws can be a riser for the fracture. Again, here there is loss of alignment and catastrophic symptom. What are the risk factors? I think they are likely. We don't have any evidence on these risk factors, but I think that we have to consider first the patient, bone density, but also, as Dr. Mock was mentioning, bone architecture. And some patients who are smokers and who have good BMI, good T-scores in the densitometry, they had very poor architecture and they have very weak bone. Non-compliance postoperatively and sagittal imbalance, in my opinion, are very strong drivers of this kind of failure. And the surgeon is a risk factor. So primary end plate lesion, too high implants, tilted implants, lack of posterior support can be a factor, having stress risers like screws or plates, or improper sagittal alignment. So these are things that the surgeon can fix before he leaves the operating room. So what are the suggested treatment guidelines? The decision has to be based on the general status, the severity of symptoms, and the biomechanics, and there's no one recipe for all. I think that delaying revision if the patient is not responsive is stupid. It is not going to solve the problem. And I have the feeling that minimalist surgery is very often a failure. So my advice is doing once the thing that is needed to do. So in revision, I suggest to restore the mechanical continuity, to get proper anchors, and to obtain proper alignment for a long-lasting result. The take-home message is, remember that large cages have less subsidence, but if they have a failure, it can be catastrophic. Second thing, prevention depends on screening for risk factors, preconditioning, pre-habilitation of the patient before surgery when you can wait, and almost always we can, to preserve implants, to align properly the patient. And when the disaster happens, restore alignment, forget. Many times you have to forget that less is more in these cases. Better not to wait. And I think that you get best results when you have immediate one-shot revision. Thank you very much.
Thank you, Pedro.
And the solution?
Yeah, now I'm going to prove you guys that Pedro is not the only one expert in complications. Can you put the case once more? Okay, so just remember, you guys, this is a female, 71 years old, with a mild degenerative scoliosis, back pain, and we did a 3-level standalone, hoping that this BMG helps us because of the osteophytes, and we have some discussions here about the good effect of the osteophytes preventing failures, but she didn't go so well, and she's presenting now 6 weeks after the surgery with 2-level subsidence and also radicular symptom and left leg pain. So what you do right now? Raise hands if you're gonna try a little bit more conservative treatment, or we need to do something. Who is going for percutaneous fixation? Open fixation?
Can I comment this?
Yeah, sure.
So I think that the rationale for percutaneous fixation is strong when you have a strong anterior column.
Before subsidence.
Once you have subsidence, I think that percutaneous doesn't achieve, you don't have the chance to get a posterior fusion mass. So when you do a posterior fixation and a posterior fusion with graft, it's like a race against time. So if the graft makes a fusion before the implant fails, you are right. But in percutaneous, you don't have this pro of making a posterior fusion.
So after this comment, who gonna do percutaneous fixation? Raise hands. That's what we did. So, actually, she had a foraminal stenosis, and we did a small foraminotomy and a percutaneous fixation, and we lost the pedicle on the L2 level, and the patient didn't go well with this fixation. And here, because she's very sick, we tried to wait a little bit and see if the fusion gonna happen. But 6 months after the surgery, she was doing so bad. And what you do now, Juan?
Minimalist.
Yeah. No, I mean, to me, once you start having this, once I have a real subsidence, the patient go back with the radiculopathy. To me, it's an open surgery, big decompression, open instrumentation, and since in this case particularly, because the bone density was so bad, I will obviously augment each screw and then cross my fingers.
Mm.
And go multi-levels.
Yeah.
How long?
And then also the balance, You can see, I'm sure that Pedro is going to hit that. Balance is a big deal, and then if most of the time you're not on balance to start with, subsidence is a big deal also. That happen a lot in adjacent segment failures. If you guys like to do standalone, you might better make sure that the patient is on balance, because you're going to create a huge subsidence if not.
This is a note case we don't do anymore.
Yeah.
I think that a quick analysis of the balance of this patient. She has 45 degrees of pelvic incidence. She has about 0 degrees of lordosis. So you need to increase by 50 degrees the lordosis. So
and you get
it's going to be very, very difficult. May I be provocative?
Yeah, sure.
Probably the best solution for this patient is to tell her, okay, you started minimally invasive. Now we change our expectations, because your solution is probably going to be T2 to ilium and 1 big PSO. Yeah. Maybe you could do less and go into lower thoracic spine, but still you have a high risk of failure there. So probably in this case, unfortunately, it's going to be like this.
So I'm going to accept your opinion.
Exactly.
And we did a T12 actually. So try, again, this is a very sick patient, and we try to stay in the lower thoracic spine. And this is how she finished. This is 6 weeks post-operative.
Okay, now you can complete up to
and
T2.
You go to T4, then you go to T4, and then you go to C2.
Yeah, but actually, we finished the case right here, because she doesn't want to go surgery anymore.
Yeah.
And she's still not good. She's still suffering of back pain, and she's still progressing on the PJK. Yeah. But now she's 6 years after the index surgery, and she's like this. But now she have a contraindication for surgery because of the cardiac problems. So,
it's
any question?
Yeah.
Opinions?
I think, Rodrigo, this is a problem for all of us, because for us it's overwhelming when you have the responsibility to take care of a patient and you fail, and the patient is worse than before, and you want she to be to be well, and then you propose to do little because the expectations she came to you to do MIS, and you want to keep on that. And unfortunately, what we should do is to tell, okay, life is bad for you and for me, and now we have to remanage our expectations. And now the solution is going to do far beyond what you imagined.
Yeah. So yeah, and then Rodrigo, can you go to the bone density?
Oh, yes.
Because you know what? Yeah. So
This is a tricky one, actually.
So I always say, look at that numbers, yeah, on the right side of the screen. You see the T-score.
It's
What
minus
is,
2.1.
Okay, minus 2.1 on the femoral head,
No,
but then the spine is not that bad, correct?
The spine is good, actually. The
Yeah.
spine is plus 1.1.
Yeah, so something that I usually, if I'm going to give you what I've been learning tip and tricks on osteoporosis is the following thing. To me, the subsidence starts in the clinic before the surgery. So as a rule of thumb, I don't fuse anybody without having a bone density with me. Why? Because I'm a big believer, if you are going worse than -2 on the T-score, is your down payment for a subsidence on the patient. So when I have a -2, I always tell the patients, go out, take your Forteo, the Teriparatide or anything else, and then we'll talk when you get better. If you're a -2 and you're a smoker, you say you have to show me that you're willing to work with me and stop smoking, get your bone better, go to your rheumatologist and come back, yeah? And then that's the first thing. To me, the mothership of subsidence is the bone quality. The second thing is a cage sizing in the OR, as Dr. Pimenta mentioned. So to me, for example, no one is a candidate for more than a 10 height cages. I can count in my hands at the time that I've been using 12 height cages. So if your height is 4, I put an 8. If your height is 6, I put an 8. If your height is 8, I put a 10 cage. So why? Because the more you distract in the OR looks great because the patient is relaxed and you can feed everything you want. But the more pressure you put on that end plates, the more chances of suicide. That's the height. The second one, Dr. Pimenta mentioned, the width. And we learned from him the classic shoe snow. The wider the cage, the less chances of subsidence. Yeah, so you can put a 26 cage, it's better than 22, and 22 is better than 18, and 18 is better than whatever is on the market. Yeah, and then the third one is the length. Make sure that you go through and through one diaphragm to the other ones. Yeah. So we have two, bone quality and cage sizing. The third one that is very important, as Pedro mentioned, is carpentry. Doing lateral surgery, end plates are golden. You have to keep this end plate intact. You may get a little bit of erosion in the middle of the end plates, but all the periphery is golden because that's what's holding the cages and providing the subsidence. So you have to be a good carpentry. There is another principle that I use that sometimes doesn't work is there is a very nice study that's saying because the way that we are made in our architecture, the inferior end plate of each segment is stronger than the superior end plate. So when you see subsidence of the lower end plate, it's osteoporosis, whatever. But when you see subsidence on the superior one, it's the surgeon. Yeah? So you have to take advantage of that as well. So the third one is, the fourth one is the segment instability. Pedro mentioned very good. So when you have vacuum phenomenon or good lordosis, that segments take the cages very good because actually the instantaneous axis of rotation of the spine is not getting through the cage exactly in the middle of the cage. It's running more posterior, especially in the lumbar areas, So the more lordosis you have, the more posterior is your instantaneous axis of rotation or your plumb line, then the cage are going to be loaded less because it's getting more posterior, yeah? So sagittal balance is a big deal. And then the last one is, otherwise you have to play with all these 5 factors. I'm sure if you do that, your subsidence is less. But as I mentioned before, the mothership of subsidence is the bone quality. If I have a patient with worse than -2, it's not a surgical candidate for me. And most of the reviews you get in Google, and look my name and the reviewers, the negative reviewers are actually patients that have been denied to get surgery. And most of them are patients like this that I tell, listen, I don't care what they tell you, your people, you are not candidate for surgery in my own hands. They get mad, they go there and they write the bad reviews, but I think you're helping them out.
Let me ask a question. James, you think there's a cutoff on BMG to deny surgery for the patient and treat the patient before?
I think negative 2.5. I think if it goes below that, you're dealing with severe osteoporosis.
Surgical
correct? So especially when you're talking about multi-level fusions. But sometimes when you're faced with patients who, for some reason or other, usually in a revision setting, have to have an operation, then we have treated patients for Forteo for the full 24 months. And then when they're that disciplined, usually I think they'll be a good candidate.
Improve a lot, actually.
But it's usually an open technique that is required, I feel like, in a patient with severe osteoporosis.
Yeah, and I have one question for you. Any opinion on the use of Forteo off-label to treat fractures? Because there's some evidence in humerus pseudoarthrosis or in dense pseudoarthrosis, and they heal under treatment with Forteo. Do you have any experience of treating these complications with?
I don't. No, I haven't used Forteo as the definitive treatment for these kind of difficult iatrogenic fracture.
And actually, it's an SRS good abstract. I think it's a paper already. They were showing that when you treat patients with Forteo after big scoliosis deformities, actually they fuse better. Believe it or not, the fusion rates are higher. It's an amazing medication. Unfortunately, it's forbidding the price. It's very expensive, but I think it helps us out a lot.
We'll see what happens in August 2019 when it goes off patent.
That's going to be generic. That's going to be great.
Hopefully, yeah.
So we should have 3 minutes. The audience have any question?
No, it's just $1,000.
Before the screws. Sorry, after the screws, exactly. I place the patient in, I have done this twice or 3 times. Lateral decubitus, then percutaneous screws without the rod, then the approach to the lateral spine. Then I use long the needles because with the short ones you don't get there to the retractor. And then I put them into the end plates and I cement from deep and then to superficial. And after that, I do the cage and the rods. That's the sequence.
Dr. Pimenta also have some experience supplementing patient in a lateral position to try to prevent subsidence. You want to put a comment? Pimenta? Cement in the lateral preventing subsidence?
Well, our experience we did this, and we don't do this anymore. We tried all sorts of cementations before the screw, through the screw, direct, lateral, just touching the end plate, feeling all the vertebral body. Nothing happens. Nothing helps. It's not recommended. In my opinion, we don't have better results by augmentation. Actually, it may cause more difficulties if you need a revision.
Yeah. Related question on just alternate forms of instrumentation, whether they be, fenestrated screws or cortical screw technique or anything other than, our traditional pedicle screws with or without cement. Do you think that's of any value, or do you have any experience, positive or negative, with that?
You'll have experience,
I think
right?
increase the points of fixation helps, but I don't have any thoughts on different type of instruments.
Yeah.
I don't think it's.
Sembrano likes cortical screws.
No, I haven't used them at all.
To answer to that question, we have a strong discipline to avoid cementation of the screws because it makes probably worse revisions if you need them. Sure. It's one opinion. And we use the same kind of implants but increase density. Second thing, sometimes we use sublaminar taping to enhance the pull-out resistance of the screws. But anything fails if you don't balance well the patient. So if you have a more than one level construct and you don't balance the patient, it's going to more likely fail with more implants.
So cemented screws just prevent the screws to the pull-out effect,
Of
right?
that
Doesn't
screw.
increase anything on the axial plane. So
Of that screw.
Simran?
No, it's a big problem. I don't think any of us has a perfect answer. But I would just like to make a comment. I understand the rationale for the cage heights. And if you put two tall cages, it puts a lot of stress on the end plates. But it does present a dilemma in terms of sagittal alignment, because if you think of lordosis correction as anterior column lengthening and or posterior column shortening, and particularly if you're placing percutaneous screws where you're not really achieving posterior column shortening, then you're only left with lengthening anteriorly, and then you really have that big dilemma. And should we just be doing Smith-Pearson osteotomies on everybody and using shorter cages? And I don't know the answer either.
We have collected some experience on that. The first experience very early is that lateral doesn't correct sagittal misalignment. And there is some evidence in the literature. It's very good to correct coronal misalignment, but not for sagittal. Second, this is not true for everyone. For cases where you have vacuum in every disc, and you need to increase by 25 degrees the lordosis, and you do one standard LLIF and 4 XLIFs or 4 lateral fusions or all ifs, anything, you can increase by your goal. If you need to increase more, you need to do something additional. That something additional in our strategy is or anterior release or posterior shortening, Ponti osteotomies or better 3-column osteotomies, and that's it. You can combine an anterior release with a Ponti osteotomy, but increasing the height of the cage is only increasing your failures. It's our experience.
I agree. Okay, so thank you for a good discussion. Thank you for the panelists. See you guys tomorrow.
Thank you.